And welcome again. It's my pleasure as Editor-in-Chief to welcome Jason Kovacic and his work that's been selected as an editor's choice for catheterization cardiovascular interventions. The manuscript is comparison of 6 risk scores in patients with triple vessel coronary artery disease undergoing PCI. Competing factors influence mortality, myocardial infarction, target lesion revascularization. This work came from Mount Sinai Medical Center and I think addresses an important question. We're going to ask Dr. Kovacic to talk with us about why it is that the clinical factors may be so important as we try to reconcile the angiographic factors in our approach to intervention. So, Jason, welcome. Tell us a little bit about your thoughts behind starting this research.
Sure. Thanks very much, Dr. Bailey, for the opportunity to speak today for CCI. It's great to be able to share some of our work with you and with the listeners. We really conceived of this study back several years ago when it really became obvious to us that there was increasing reliance on the syntax score to triage patients into whether they should have PCI or to have bypass surgery. And as I'm sure you and the listeners are aware, that's become even more so the case recently. We really felt that there was a population of patients that come to the cath lab with significant coronary artery disease that really weren't very well served by that just bland triage into PCI versus CABG based purely on a syntax score. And we really started to look at the patients that were undergoing PCI in our institution to see if we could really come up with a better algorithm, or at least start to make headroads towards a better algorithm for triaging who should and who shouldn't have PCI versus CABG, beyond looking straight at the syntax score alone.
One of the struggles I hear about from clinical interventionalists is how they can arrive at a syntax score to begin with. Maybe I could have you just speak a little bit to how complex it may or may not be to get syntax angiographic assessment in patients.
Sure, I completely agree with that. And at our hospital, Sinai, we actually have embedded in the cath reporting system the sort of automatic calculation of the syntax score, so that you're forced in our reporting system to pull up lesions, left main, LAD, bifurcation, and that triggers the calculation of the syntax score with the inputting of a few more variables like the length of lesions, calcification, and so on. But even with that semi-automated calculation in our reporting system, it still can be very challenging to accurately calculate a syntax score. And for instance, our fellows are forever putting mid-LAD and D1. If you put them in separately versus if you put them together as a bifurcation lesion, you come up with a completely different syntax score, and the attention to those small details can be challenging. And certainly to you've got someone on the table to properly calculate a syntax score and work out whether you should go for bypass or PCI can take upwards of 5 to 10 minutes if you're methodical and careful about it. So it certainly can be something that's challenging to do in the middle of a busy practice and a busy cath lab schedule.
Well, as has been pointed out, while angiographic assessment can vary and a syntax score can be different, I think you're quite correct that patients differ as well. So in your 580 plus patients, maybe you can just share a little bit of what you found out about how the clinical features of a patient, the comorbidities, may influence outcome above and beyond a syntax score.
Mm-hmm. Sure. So what we did was to look back at our cath lab database of patients with left main and 3 vessel disease that did undergo PCI from a period back in about 2010, 2011. These were patients, a lot of them had refused bypass surgery. There were various other reasons, such as old age, frailty, etc., that rendered them either inoperable for bypass or they just didn't want to have bypass surgery. And we went back and calculated 6 different risk scores on these patients. And that included the syntax risk score, the New York State risk score, which we do routinely here as part of our practice being in New York State, the ASEV score, the clinical syntax score, the modified ASEV score, and the NCDR risk score. And then we basically just looked at their risk score in relationship to their outcomes at 1 year, and those outcomes included death, MI, and revascularization. So to take you through what we actually found, firstly, it was very interesting. Some of the risk scores had a very normal type of distribution, such as the syntax score, but it was very interesting that other risk scores, such as the clinical syntax, have a very, very skewed distribution. So a lot of the patients with a clinical syntax score have a very low score, and there's a lesser number of patients and a reduced discriminatory ability of the clinical syntax score for patients with a high score. When we looked at outcomes, we actually found that all of the risk scores did predict mortality at 12 months, and they all did that reasonably well. However, when you get to the other outcomes, particularly myocardial infarction and TLR, what we found was that the syntax risk score and the clinical syntax score predicted myocardial infarction, whereas the other risk scores were not actually discriminatory and were not able to predict the patients that were subsequently going to have myocardial infarction. What was very interesting to us is when we looked at the incidence of TLR, of target lesion revascularization, none of these scores are actually able to predict TLR. The syntax got the closest with a p-value of 0.075. But what was fascinating to us was that some of these risk scores that weighed more heavily on clinical risk factors, and particularly the NCDR score, paradoxically inversely predicted the likelihood of having TLR. So that is, the patients with the highest NCDR risk score actually had the lowest incidence of TLR versus those with the lowest NCDR risk score had the highest rates of TLR. So when you combine all of those competing factors now into working out major adverse cardiac events, including death, MI and TLR, those factors tend to compete against one another, so that the discriminatory ability of several of these risk scores was significantly reduced. We then went on to look at in more detail comparing these scores using a ROC curve analysis, so the area under the AUC curves, and really confirmed these findings. Certainly for mortality, the best score was the ASEF score, followed by the clinical syntax. But when we looked at major adverse cardiac events, the best score for predicting major adverse cardiac events was the syntax score, but it had an AUC value of only 0.62, which really isn't that discriminatory. Some of the other risk scores had AUC values approaching 0.5, which is equivalent to the toss of a coin. So really the summary of the findings is that all of the scores are reasonable for predicting mortality, but for predicting other events, including MI and TLR, some of the clinical factors tend to cancel out against the anatomical factors, nullifying the utility of these scores for predicting major adverse events as a composite outcome.
So it's great to hear, first of all, that you did essentially your own quality assurance investigation here. You took a number of different ways of looking at these patients. I think what you discovered is that we're not as good as we thought we were going to be with any of them. That's what you just said. And that there still is a need to try to get better at improving and predicting who's going to benefit and who isn't. Mm-hmm. From this, did you come up with an even new score now, or what pieces of each of these do you think are the features that as a clinician I want to know about when I'm trying to make that decision? Is it age? Is it diabetes? Is it gender?
Sure. Now, in this initial publication, we didn't set out to try and come up with a new risk score. We thought that would be better served by a very meticulous and prospective approach to make sure that we weren't missing or not accounting for any variables. But I think what it really shows us is that you have to be very careful of what these respective risk scores were designed to do, what they actually measured as their primary outcome. For example, it was the primary outcome of the score when they were deriving the score. Was it death? Was it major adverse cardiac events or other outcomes? And depending on what you're actually looking to predict, I think you really have to be careful which risk score you apply. So as we saw here, TLR was actually reciprocally predicted, paradoxically, predicted by some of these risk scores. And I think if you're looking to see what your chance of having to take a patient back for revascularization is in a younger patient perhaps compared to what the risk of mortality is in an older patient, the risk scores that we're going to need to derive for this are likely to be very different. And as we've seen at the same time in interventional cardiology, there's really been an explosion of other risk scores in other areas, for instance, predicting contrast nephropathy, predicting bleeding, stent thrombosis, and really those risk scores reflect the need that if you really have to know what question it is you're asking when you turn to a risk score to calculate the likelihood of an adverse event.
So one of the things I'm taking away is that how I use this could be different. If I have a 90-year-old patient with the same syntax score, and I'm most concerned not with mortality, but with the likelihood of revascularization, I might choose differently than if I have a 60-year-old where the mortality becomes a more important feature. Is that part of what I'm hearing you say is how this could be used?
Yeah, that's spot on. I completely agree, Dr. Buddy. And that was really actually one of the reasons we started doing this study in the first place, is because we noted in our cath lab that just because the syntax score was 25 or 26, and that should triage the patient towards bypass, if the patient's 90 years old with a reduced ejection fraction, they've had a previous non-debilitating stroke or something like that as well, you're really not going to want to send that patient for bypass surgery, and they may be far better off having PCI of a couple of proximal tight stenoses. So I think those are the kind of things that we need to start to look towards to incorporate into some of the risk scores as we go forwards.
Dr. Kovacic, I would like to thank you so much. I think that your manuscript has really helped focus us on questions that still remain. It really identifies the differences between just angiographic and the clinical groups, and we look forward to future investigations informing us more specifically about how we can choose better for our patients.
Thanks very much, Dr. Bali, for the opportunity. I'd like to thank all of the co-investigators that helped with this work, Dr. Sharma, Dr. Kinney, particularly the director of the cath lab. It was a team effort, and a lot of work went into this study, and thanks for the opportunity of sharing it with you and the CCI listeners.
Well, congratulations again to your team, and we look forward to perhaps the Kovacic score.
Okay, we'll see. Thank you.
Okay. Take care. Bye-bye.
Bye.